Let's get started. My name is Jose Castillo Mancilla. I'm a volunteer clinical assistant professor in the Division of Infectious Diseases, and I'm here representing Dr. Wendy Armstrong, our division chief, who could not be here. She's very disappointed she couldn't make it, but asked me to step in and introduce our speaker here today. I couldn't say this enough, but it's a true privilege for me to introduce Dr. Kristine Erlandson as our DOM Grand Rounds speaker. Dr. Erlandson is a professor of medicine at the University of Colorado Anschutz Medical Campus, and is also associate division head for research in the Division of Infectious Diseases. She completed her medical degree at the Southern Illinois University, and this was followed by internal medicine residency and chief medical resident year at the University of Nebraska. She then came here to Colorado, where she completed a fellowship in infectious diseases and stayed with us as faculty ever since. She also holds a Master of Science in Clinical Science and is currently completing a certificate in Dissemination and Implementation Science. Now, Dr. Erlandson's research focuses on the intersection of HIV, aging, and physical function, and she's considered really one of the world leaders in the field. She has led multiple and leads multiple NIH-funded studies, currently including the Health and the Triumph trial, and she explores exercise as part of her research and pharmacologic interventions to improve frailty and muscle function in persons with HIV who are aging. She also currently plays a key role in the Recovery Initiative that investigates the physical and cognitive impact of long COVID. Now, personally, as an HIV researcher, I can really attest to the great advances that Dr. Erlandson's research has had on the field. I think it's clear that our patients with HIV are living longer and happy and healthier lives, but they still are at risk for some severe non-AIDS comorbidities and accelerated aging compared to the general population. And I think this is where Dr. Erlandson's research plays a critical role as our patient population continues to age. Multiple discoveries can be attached to her name, but I think three are the most critical that stand out, at least to me, and to the general HIV research community. First, Dr. Erlandson was the first one to really establish and demonstrate that frailty is actually a driver of residual immune activation inflammation in persons with HIV, which I think has been critical to understand the pathogenesis of non-AIDS comorbidities in our population. Second, Dr. Erlandson pioneered the use of GLP-1 agonists for the treatment and reversion of metabolic dysfunction associated with steatotic liver disease recently in a large clinical trial. This is one of the main contributors of morbidity and mortality to our population, and that's critical intervention from her research group. And last, Dr. Erlandson has established the predictors of functional impairment in persons with HIV who are aging, and she has really established a framework for interventions, including pharmacologic interventions and exercise to revert and prevent frailty in this population. In terms of her awards, I was on page 25 when I realized I should just tell you a few of them. She's a fellow of both the American College of Physicians, the IDSA, Infectious Society of America, has received multiple accolades, including the recently awarded mentoring excellence in mentoring from the DOM, and also Gilead Sciences Research Scholarship in HIV. I like to call her, I think she's what is called a mega mentor. She has mentored everybody from students, residents, fellows, faculty alike, not only national and internationally, and has catapulted their careers. Now, on a personal level, beyond a colleague, collaborator, Dr. Erlandson is a dear friend. I learn a lot from her every day, and I have learned a lot over the last almost 2 decades that we've been working together. And I'm sure that many of you will learn a lot from her today. So without further ado, let's introduce our speaker, who will talk to us today about beyond survival, optimizing health span in the aging HIV population. Dr. Erlandson.
Thank you, Dr. Castillo, for that very nice introduction. And as he mentioned, I'm going to talk today about optimizing health span in the aging HIV population. My research or my disclosures are listed here. And as is typical for medicine grand rounds, I wanted to start with a couple of cases that really illustrate kind of the breadth of HIV and aging. The first case is a case that I actually saw as a fellow here back in 2008 with Dr. Madinger, who's sitting there in the third row. And this is a patient I've continued to follow for the last 15 years or so in clinic. This is a 54-year-old female who was brought to the emergency department from DIA after she experienced profound hypoxia on a flight back. She had had this extensive workup for anemia over the prior year, and no one had really figured out why she was anemic. She was subsequently, during her hospitalization, diagnosed with HIV/AIDS, found to have a CD4 count of 3, and pneumocystis pneumonia, really explaining her hypoxia. She's since recovered nicely, has a CD4 count in the 600s, and has had a suppressed viral load for many years. The second is a patient I've been following in the HIV clinic for about the last 5 years. This is a 61-year-old male who's had HIV for over 30 years. He's on a single tablet for his HIV regimen that includes bictegravir, tenofovir, alafenamide, and emtricitabine, more commonly regarded as Biktarvy. And he presents for a routine follow-up visit with concerns related to increasing mobility impairment following a recent hospitalization. Notably, he had a recent fall and has recurrent falls, has a T-score of -4.1 despite zoledronic acid and teriparatide, has weakness, prediabetes, difficulty managing his over 15 medications, and also complains of significant social isolation. So I think these two cases kind of illustrate some of the variety that we see in the HIV clinic. I'm going to talk a little bit more about what chronic HIV care looks like in 2025, talk about some unique risk factors that contribute to a decreased health span, which I'll define in a few minutes, in people with HIV, and then talk about some interventions that Dr. Castillo mentioned that may help to improve the health span in people with HIV. So I know we're in a room of learners, and some of you may not have thought about or seen a patient with HIV for many years. So I thought it might be helpful to just kind of recap the tremendous progress that we've seen in HIV care over the last 40 years now of the HIV epidemic. So it was back in the early 1980s when we first saw the cases of HIV in the US, more commonly referred to as AIDS at the time. At that time, patients were admitted or seen in clinic with really profound wasting, lots of opportunistic infections, and CD4 counts of 0 once we figured out kind of how to measure and assess HIV. AZT was the first antiretroviral that was approved in the late 1980s. And although this had some success initially in trying to suppress the viral load before people began to develop resistance, it also had a lot of toxicity, particularly at the doses that we needed to use at the time. Some of those toxicities were long-lasting: mitochondrial impairment, wasting, impact on the muscle, and then some of the facial lipoatrophy that you might see still on some patients today that didn't really resolve. It wasn't until the late 1990s before we saw the era of highly active antiretroviral therapy or combination antiretroviral therapy, when we could combine 2 or more medication classes and finally achieve successful viral suppression. This really transformed HIV, became a much more manageable chronic condition, but a lot of those therapies were still associated with pretty tremendous toxicity. The protease inhibitors, as you can see in this picture, we saw something called the protease paunch, or the big belly associated with protease inhibitors, a buffalo hump, lots of metabolic disturbances. The integrase inhibitors, which now kind of form the backbone of a lot of our therapies, rolled out in about 2007, 2008, more in clinical practice. And then over the last 15 to 20 years, we've seen the introduction of pre-exposure prophylaxis. We now have people that start therapy almost the day that they're diagnosed, sometimes within hours of diagnosis. And so HIV has become much more of a manageable long-term condition. And we also have this concept of U equals U. So once someone is on treatment and undetectable, they're essentially untransmittable to other people, which has decreased the stigma of HIV tremendously. So as you can see, depending on where someone came into this HIV timeline, someone who was impacted with HIV in the early 1980s and is still living today had a much different course of HIV treatment than someone that might be diagnosed today. So the result of this, however, the decrease in new cases of HIV and people who are aging successfully on antiretroviral therapy means that the majority of people with HIV in the US are now aged 50 or older. The number one reason probably is that people are successfully growing older with their effective antiretroviral therapy. We saw that in case number 2. We do still continue to see new diagnoses of HIV in older individuals. These often are presenting late with delayed diagnoses, symptoms that may overlap with typical things that we see with increasing age, like fatigue, and we saw that in case number 1. But the result is that the proportion of people with HIV age 50 or older is estimated to reach about 75% of the population of people with HIV in the US and most of Europe by 2030. So over this time frame, we've seen a drastic improvement in the lifespan of people with HIV. This is shown in the top 2 bars here with the circle and the triangle kind of in that bluish color. The triangles represent people with HIV, and you can see that their lifespan over the last 15 or 20 years has mirrored that of people without HIV and is almost the same. We think that someone who has HIV will probably have about the same lifespan. At the same time, we can look at the health span, or the time that someone takes before they go on to develop an additional comorbid disease. In the bottom half of the figure, in the orange circle and orange triangles, show the expected time for someone who's 21 before they develop an additional comorbid condition. And this is close to 30 years in somebody without HIV, so close to their 50s before they're developing comorbidities, but closer to 10 years in people with HIV. So almost 20 years earlier, people with HIV are beginning to develop comorbid conditions. And as you can see by these relatively flat graphs, that proportion or that change really has not happened over the last 20 years. There's certainly some comorbidities that we see more common in people with HIV. One of those is cardiovascular disease. Cardiovascular disease risk is about 50% higher in people with HIV compared to those aging without HIV. And cardiovascular disease mortality is probably one of the leading causes of death in people aging with HIV. Interestingly, cardiovascular events are not very well predicted by our traditional risk scores like the ASCVD risk score. And this was really the premise of a large trial called REPRIEVE that came out a couple of years ago. The REPRIEVE trial looked at about 7,000 people with HIV and randomized them to a drug called pitavastatin, which is a moderate intensity statin. It doesn't have any drug interactions with protease inhibitors, which is one of the reasons it was chosen for this study. And they followed people for 7 years looking at cardiovascular events. There was a 33% reduction in the people that received pitavastatin compared to placebo. And this was a population that didn't necessarily have an indication for a statin. They had a low or moderate risk for cardiovascular disease based on the ASCVD risk score. This study really revolutionized kind of how we think about cardiovascular disease, changed our guidelines for when we start statins, which is now in essentially anyone with HIV age 50 or older, or 40 or older, regardless of what their cardiovascular risk score is. So as suggested by this increased comorbid burden that we see, cardiovascular disease being one of those examples, it seems that people with HIV may be aging differently than people without HIV. And one way to think about this is the impact of chronologic age versus biologic age. So if you take a look at these 2 cars in the picture, the car on the left and the car on the right were manufactured in the same year, although the car on the right certainly appears much older than the car on the left after years and years of exposure to the elements, kind of not being cared for particularly well. We can see a difference in how these cars are aging. And we can think about that with biologic versus chronologic age. Chronologic age is represented by what your birth certificate suggests your age should be, whereas your biologic age is how you wear and tear, how you might feel or function, and kind of the age that you perceive you are. And this increased burden of comorbidities has raised interest in HIV as a condition of accelerated aging, where we see a disconnect between the chronologic and biologic age. We see this in other diseases or disease processes such as cancer, rheumatoid arthritis, kidney disease, diabetes. But if you look at the blue line in the middle, you can see a nice correlation between how chronologic age and biologic age increase over time. But what we see with HIV infection is at the time that someone acquires HIV, there seems to be an acceleration in their aging so that some of their organ systems speed up and may seem a little bit older than what we would expect for that person's age. After antiretroviral therapy is initiated, this seems to slow down a bit. It may, however, continue to accelerate to an extent, or it may just continue in parallel, but people may have potentially those earlier diseases 5 or 10 years before their counterparts. There's certainly a lot of factors that may contribute to accelerated or accentuated aging in people with HIV. HIV virus is one of those. Toxicities from antiretroviral therapy could be some. There's a lot of structural inequities that may occur more commonly in people with HIV, such as unstable housing or food insecurity. Biobehavioral factors that probably occur more commonly in people with HIV, such as poor diet, low physical activity, or low self-efficacy and loneliness, as well as the impact of stigma, which has improved some, but not completely. And in combination, all these factors probably contribute to an accelerated or accentuated aging process. So this isn't necessarily just semantics or theory, but it actually impacts how we think about the patients that we're seeing in clinic who have HIV. One example is anal and cervical cancer, which occur much more commonly in people with HIV. In fact, we have an established anal rectal disease clinic run by Dr. Dunlevy here in the infectious disease clinic because we have such high rates of anal dysplasia or changes in risk for anal cancer. And we recommend screening for anal cancer and for cervical cancer at different rates in people with HIV compared to people without HIV. Diabetes is another example. We see a higher prevalence of diabetes in people with HIV, as well as a higher progression from pre-diabetes to diabetes. And so we screen differently for diabetes in the HIV clinic. I mentioned cardiovascular disease and starting statins at a much earlier age. And then we also think about osteoporosis differently. The second case that I presented had a T-score of -4.1, and there's multiple factors that probably contribute to osteoporosis, including some immune activation and immune changes at the time of antiretroviral therapy, as well as some of our older therapies that may have more toxic effects on bone. Because of this, we actually recommend screening with a DEXA scan in men with HIV at age 50. And this is in pretty stark contrast to the US Preventative Task Force services who don't recommend screening in men at all, or in some of the osteoporosis guidelines who may suggest screening at about age 70. And so there's been a growing interest in using what we call the geroscience approach to how we think about aging and the development of different comorbid conditions in a lot of different disease processes, and HIV could be one of those. The geroscience hypothesis is that there's all of these hallmarks that are kind of these underlying processes that contribute to the aging and are a driver of essentially all chronic diseases that people develop. This could include things like chronic inflammation, which we know occurs more commonly in HIV, changes in the gut, telomere changes, and epigenetic or methylation changes. If we can target a lot of these different hallmarks of aging, then ultimately we can delay the onset of chronic diseases rather than having very disease-specific focuses for each condition. And overall, the hope is that we can then expand not just the lifespan, so we're not necessarily trying to come up with an anti-aging drug, but that we can prolong the time before people begin to develop comorbid conditions, decrease the cost for healthcare for older adults, as well as keep people in their home and improve their quality of life with time. There's a significant overlap between many of those hallmarks that we think of in general aging and the hallmarks of what we see happen as part of HIV infection. We see the same or different changes in dysbiosis with HIV. We see markedly higher levels of inflammation in HIV. We see changes in a lot of these other hallmarks, which I'll talk about in a minute. And this has really led to the concept that HIV probably could be, or is a kind of a representative disease of accelerated aging. And if we can target these hallmarks, then we can potentially slow aging and learn about aging in all different disease processes. Some examples of ways that other studies have shown HIV impacts the hallmarks of aging. This was a study that looked at epigenetic age, or kind of the DNA methylation patterns on the genome. Here you can see people with HIV in the red line and an uninfected group in the black line. And those with HIV had an advancement in age throughout their lifespan of about 5 to 10 years, even with effective antiretroviral therapy. This study shows telomere length changes in people with HIV, men in the blue color and women in the pinkish color. And you can see a decline in telomere length that tends to stabilize a bit with antiretroviral therapy, but still continues to decline, particularly in women, suggesting that there may be an impact of HIV and antiretroviral therapy on this hallmark of telomeres. Lots of different data that has suggested mitochondrial impairment in people with HIV, both as a result of HIV itself, as well as a lot of the old antiretroviral therapy, and potentially some of the current antiretroviral therapy. And then several other studies have shown increased inflammation, dysbiosis, and multiple of these other hallmarks that are impacted by HIV. So ideally, we can study people for 80 years and see when they start to develop comorbid conditions, but in the current funding situation, that's probably not particularly possible or very doable. And so we look for different ways that we can study aging that will give us answers sooner than 80 years. And some of those are molecular markers that I mentioned, like epigenetics and transcriptomics, proteomics, some of these omic markers. Our group has been particularly interested in functional aging, or how people can perform as a marker of their aging, kind of as a biomarker of aging. So things that we could do in clinic: how fast can someone walk across a room? How well can someone get up from a chair? What's their grip strength? Things like that that can tell us a lot about the aging process without expensive labs, and are probably more meaningful to the patient who's experiencing these on a daily basis. So to bring some of this together, we know that people aging with HIV probably develop comorbidities at a faster rate, as shown by that red dotted line. Ideally, we can bring them to this normal aging curve, but even more ideally, we can help them to age with these sort of geroscience interventions that target multiple of these hallmarks and delay the onset of development of different comorbid conditions. So what interventions can target these hallmarks or mechanisms of aging? Our group has been most interested in the impact of exercise. So these don't have to be completely novel interventions, but we know that exercise can impact numerous different hallmarks of aging. It has an impact on the immune system, impacts the brain, is anti-inflammatory, can improve mitochondria. However, at the time that we kind of started into this field, gerosciences was a new concept, and we didn't know a lot about how exercise might impact these hallmarks and some of these functional outcomes of aging, particularly in people with HIV. People with HIV may have different responses to exercise compared to people without HIV. We know that they have, many of our older adults in particular, have mitochondrial toxicity from older therapies. Maybe their mitochondria might respond differently to exercise. Many of them had prior wasting that may not respond as well in terms of muscle mass in response to an exercise intervention. We also have an older adult population with a lot of pain. Might they experience more adverse events in the setting of an exercise intervention, or more injuries? In some disease processes, we see that higher intensities of exercise actually worsen inflammation, and we didn't know if that might be the case in an older adult population that has high levels of inflammation. And so we really didn't know how much is enough and how we should counsel our patients when they ask, or when we're trying to counsel them about exercise. And so this led to a study to try to understand some of these questions that was the basis of my K Award back in 2014. It was called Exercise for Healthy Aging, and we enrolled about 70 people in the Denver metro area, age 50 or older, who were previously sedentary. We had half the individuals that had HIV and half that did not have HIV, and we had them come in for 6 months of supervised exercise over in the what was the Leprino exercise lab, now in Anschutz Health Sciences. The participants were randomized to a moderate intensity or a higher intensity of exercise, just based on the target heart rate that we assigned them. And we looked at lots of different functional markers, kind of as our primary outcome of how people are aging. And you can see the primary outcomes there on the in the figure on the right. Those with HIV are shown in the red bar, and our control population are in the black bar. Their percent improvement from baseline over the 6 months of the intervention shown on the bottom axis. And then along the side, you can see lots of different functional measures that we looked at. How fast can someone stand up from a chair? How fast can they walk a quarter mile? Some strength outcomes, and a VO2 max, kind of the gold standard for exercise endurance. What you can see first is that people with HIV in controls actually had pretty similar improvements across almost all of these measures, with the exception of a couple of markers that actually improved to a greater extent in people with HIV, which wasn't necessarily what we were expecting. We also saw really impressive improvements in a lot of our strength markers, and realized that this older adult population probably is not doing much resistance exercise and really benefited from muscle-focused exercise interventions. I don't show the data here, but when we looked at the moderate or the more intense physical activity, we saw almost the exact same changes with a little bit greater improvements in some of these strength markers. Another thing that we can think about with aging is body composition changes that occur. We know older adults tend to lose muscle mass and gain fat mass, and we saw a bit of a reversal of that. So both groups tended to gain muscle mass and lose fat mass, which suggested some anti-aging effects there. In some studies led by a couple of students, a medical student and an MPH student, we also did qualitative interviews to assess how things were improving in terms of outcomes. They talked about pain, or a lot of our participants talked about pain and social interactions. The one participant noticed I used exercise to help build an inner core and bring my pain down to a minimum. And another participant noticed improvements in social interactions. It pulled me out of always wanting to be alone. So important outcomes that can impact older adult care and things that we were seeing improvements in with exercise. In terms of some omic measures and some of those hallmarks, we did look at some measures of epigenetic aging of the skeletal muscle on skeletal muscle biopsies with some studies led by Colleen Julian's group. The figure on the right, or the left, shows some DNA methylation patterns. I'm certainly not an expert in DNA methylation, but you can see in the kind of the blue and greenish colors, the people without HIV, and then the pinkish and purplish colors show people with HIV. And basically they're having unique responses. So we see different responses based on people who do or do not have HIV to an exercise intervention, as well as even before exercise. We looked at an epigenetic clock specific to skeletal muscle, and ours was actually the first study to look at this in context of an intervention. The clock is called the MEAT clock, and it did not change in the context of exercise. It hadn't been tested a whole lot, so it may need a little bit more validation, but I think that it certainly raises some interest of whether we're actually reversing aging at the level of the skeletal muscle. With support of some faculty in infectious diseases and a fellow at the time, Jay Liu, we also looked at the impact of HIV and aging on the microbiome. And we looked at whether or not this is associated with some of our physical function markers, kind of our key outcome that we were particularly interested in. At the top half of this figure, you can see that several of the different bacteria were associated with physical function as measured by a short physical performance battery. And then the bottom half shows that some short chain fatty acids, kind of the byproducts of those bacteria, were also associated with functional markers. We're further interested in whether this changes with exercise. Unfortunately, we didn't have enough participants in this study to look at the changes in microbiome, but Steph just got an R21, and we'll be looking at this from stored samples in another study that we just finished up. This also suggests that there may be an opportunity for intervening either on dietary interventions or using probiotics or other things that we can manipulate what happens in the gut. We also looked at skeletal muscle mitochondria. So I talked a lot about mitochondria. We know that a lot of our older therapies impact mitochondria, and we see kind of a depletion of mitochondria in relation to people who had AZT in particular. I'll focus on the left side of this figure here, but we were looking at several measures of mitochondrial content in skeletal muscle and how those changed in response to exercise. This figure shows a % change in content after the 24 weeks of exercise. And if you just look at those first three, citrate synthase, manganese superoxide dismutase, and PGC1 alpha, these are mitochondrial enzymes that we expect should increase with exercise. And indeed, we do see that they increase nicely with exercise in the control group. However, they actually decrease or don't change at all in our people with HIV. And we wondered if this might contribute to fatigue that many of our participants experienced. Maybe they need something else to kind of help boost their mitochondria and help them have more benefit from exercise. Or it could mean that their mitochondria are working in overdrive and they're functioning really high, but they can't improve any of the content of the mitochondrial. So it certainly didn't suggest that exercise is improving mitochondria, but we needed some additional studies to investigate this. Unfortunately, exercise actually only works if you do it, and we discovered this in our participants. This was a study that was led by a medical student at the time, Alex Stable, who's now faculty at the Rockefeller, but he did an analysis where he looked at changes in pedometers that we had our participants wear throughout the study. And both those with HIV and without HIV, shown in the gray and the red color, the red lines, had this lovely increase in their step count throughout the course of the study when we had them increase the time that they were coming into the gym and exercising. But at the same time, on the days that we weren't supervising them, everyone got less and less active over time. So we weren't having this kind of continued increase in physical activity that we were hoping for. We also found that when we called all of our participants about 3 months after our exercise intervention, less than half of them were even exercising 1 day a week or more, suggesting that a supervised exercise intervention is great while people are doing it, and then they stop it as soon as you're done supervising them. So this kind of gave us a couple directions that we needed to go for the next study. So at the time that we put in this grant, there was a lot of interest, all sorts of articles in the New York Times. HIIT is the new thing. You can exercise for 5 minutes and have all of the same benefits as long as you're doing HIIT. And so we were kind of intrigued about what this might mean. HIIT are short bouts of high intensity of exercise. And there were several studies in older adult populations, nothing in HIV, but it suggested that there may be greater cardiovascular benefit. Some studies suggested we might have greater mitochondrial benefit, which we knew was something that didn't respond as well in our participants. And then they might improve, HIIT might improve functional measures more in older adults with chronic diseases. We also thought maybe HIIT would be less boring and we might get people to engage in it more after the study was over. But we, similar to a higher intensity in our other study, we didn't know if this would be safe or effective in people with HIV who might respond differently to exercise. We were also interested in how we could keep people exercising after our supervised exercise intervention. And so we worked with a colleague in behavioral, that focuses on behavioral interventions in the College of Nursing, Paul Cook, who has a mHealth intervention that does some text messaging to help support exercise behaviors, and included that as a follow-up as kind of a low-cost coach that might keep people exercising. So this was the basis of the health study, which was funded in April of 2020, shortly after COVID started. And so our study was delayed for about a year before we could actually bring people in. But we enrolled 118 participants both here and at the University of Washington. This time we enrolled all people with HIV, again, age 50 or older, who were sedentary at baseline. And we randomized half the group to do this HIIT, short exercise intervals, compared to CME, which is continuous moderate intensity exercise. We had them come in for a little bit shorter period, so for about 4 months at that Anschutz Health Sciences building for supervised exercise. And then after that, we re-randomized them to a tailored text message. All of our participants filled out a brief survey of, did you exercise today? If not, what were some of your barriers? What helped facilitate this? And then we had targeted messages that would help address the specific concern that they noted. Or they were in a control group that got just a message that said, have a great day, can't wait to see you, something kind of generic. We looked at lots of different outcomes at all these time points that are listed in those yellow boxes. And then just to give you an idea of what we mean by HIIT, the top figure here shows the HIIT intervention. So people had a lower target heart rate, and then they increased their heart rate for about 4 minutes, decreased it for a few minutes, increased it for a few minutes. And the continuous moderate intensity just had that same target heart rate for the whole time. We actually did not do the 5-minute exercise that the New York Times touted, but instead matched people on caloric expenditure between the two arms. The primary results of the health study were led by Dr. Kulik, who's in the room today. And this was just submitted for review, or currently under review. But the take home was that both groups improved significantly. So regardless of which exercise arm you had an improvement in multiple different measures of physical function. Focused on the 400-meter walk time here is kind of a key marker that we look at for function. Across all of our functional markers, we saw slightly greater improvements in the HIIT arm, but really nothing that was significantly better than any kind of exercise. We also tended to see slightly greater adverse events in the HIIT arm, more musculoskeletal injuries, so certainly something to think about if you have a patient who has a lot of pain or injuries at baseline. We have several other analyses from the study that are currently underway, including lots of different mitochondrial measures and epigenetic measures that will hopefully be analyzed in the next month or so. In terms of the text messaging component, we found that our personalized text messages, kind of our tailored text messages, actually did help people maintain their physical activity over time. So the tailored messages are shown in the red line and the educational controls in the blue line, and either measured by objective measures by actigraph or by self-reported physical activity. We found that people had higher levels of physical activity getting these text messages, even though they told us frequently how annoyed they were at these text messages. And so for many of our participants, or many of our older adults especially, we can't have them do high intensity interval training. They may have too many barriers to coming into a gym. They may be too low in terms of their functional status to even start high intensity exercise. And so there is an interest in other therapies that might help to improve physical function and help to decrease some of these comorbidities, targeting multiple different hallmarks of aging, not just one target. And this has raised the idea of geroscience-focused therapies, or what we call gerotherapeutics, so ways that we can kind of slow the aging process in addition to exercise. I still think exercise is the best one, but these would be in addition. So one of those I kind of mentioned, we saw some interesting things with the gut, and so I think this raises questions about how we might be able to manipulate diet or use probiotics to change some aging. And then there's also one on here that I think many of us are familiar with, the GLPs, which have been particularly hot in the news, and many of our patients want to get these. And could they actually have an anti-aging effect, or might there be more toxicity? We hear about macular degeneration and many other potential complications with these therapies. Well, we were kind of interested in whether this could serve as a gerotherapeutic in people with HIV. As Jose mentioned, we previously conducted a clinical trial looking at open label semaglutide on fatty liver in people with HIV. Saw about a 30% reduction in liver fat. So marked improvements in kind of an early steatotic liver before people went on to develop more fibrotic liver disease. But we were also interested in what might be happening with the muscle and physical function, kind of what we think of as the one of the key aging outcomes. And so we had actually included some physical function markers, actually one of the only studies to look objectively at physical function in the setting of GLP therapies. And we tended to see an improvement in physical function. We had a fairly small study population, so few of these reached statistical significance, but we saw that people could get up from a chair faster, they could walk across the room faster, and we had a significantly lower proportion of people that had slow gait speed at the end of just 24 weeks of these therapies. This was even in the setting of people losing lean mass or muscle mass with these therapies, as we've seen in several other studies. We're looking a little bit at some of the epigenetic changes that occur in the setting of these treatments as well, and found that in this study, those that had an improvement in gait speed actually had a reversal of their epigenetic age that's on a DNA telomere clock, so potentially some anti-aging mechanisms for how these might work. And then one other therapeutic that I'll mention that we're particularly interested in is a drug called tesamorelin. This is not something that's used much outside of the HIV space, but it's a growth hormone releasing hormone, or GHRH analog. So think back to your basic hormone biology. So it's targeting the hypothalamus to release growth hormone. And it's been approved for abdominal adiposity related to antiretroviral therapy in people with HIV. There's a lot of interest previously in using growth hormone to try to improve muscle mass, help to reduce frailty in geriatric populations. However, many of the early trials had a lot of glucose abnormalities. There was concern for increased risk of cancer for giving people growth hormone. And so many of these were stopped due to toxicity. This growth hormone releasing hormone, though, is triggering growth hormone release. And so we get more of normal pulsatility with a lot less toxicity. And so we are interested in whether this drug, when used for people with HIV who have functional impairment or frailty, in combination with exercise, might help to improve physical function. This led to the TRIUMPH study, which is being conducted here and with my colleague at MGH. And we just started enrolling. We had our first participant screen last week, who will get randomized to study drug next week. So we'll be looking at many different outcomes of skeletal muscle, physical function, frailty, as well as whether we can help people self-efficacy for exercise. So I talked a lot about kind of attention to geriatric syndromes, how we can optimize functional ability and comorbidities on the left side of this figure, but there's so many other things that go into how we think about HIV care and things that happen in our HIV clinic, including primary care, addressing diabetes and cardiovascular disease management, access to food and housing, HIV management, as well as behavioral care that happen in the HIV clinic. And this has been a topic of debate in the ID community, is should we continue to follow these older patients who have HIV in the HIV clinic, or should we have patients start to go to internal medicine, and then we as HIV consultants just see them to manage their HIV care? The other issue is, as many of our patients are now 70, 80 years old, should they be going to geriatrics when many of them are experiencing geriatric syndromes at a much earlier age? Notably, there's also a shortage of HIV providers, geriatricians, and primary care, so none of these are a clear option for where we should be sending patients, but it certainly raised a lot of interest into how can we best care for this population as they're getting older. There was a HRSA SPINS, Special Projects of National Significance grant announcement that came out a couple of years ago, and Aaron Burke-Lever in the School of Public Health and Jacob Walker in geriatrics, both two of my mentees, had projects that were looking at kind of models of care for older adults and how can we start to incorporate some of these aging outcomes in the HIV clinic, or how do we think about transitioning patients to general medicine. Amelia Davis, who was a medical student here a couple of years ago, also helped us investigate some of these. We looked at different types of geriatric care models internationally, and then looked at some of the perspectives of patients in our clinic and kind of where they would want to go and how they'd want to receive their care. So one simple thing that we've been interested in is how we can potentially incorporate gait speed as a measure in the HIV clinic. This might help us to identify patients who may benefit from geriatric care. And gait speed, as simple as it sounds and as boring as it sounds, is actually a really important vital sign that we can think about. This figure on the left here shows, it was from a publication in JAMA several years ago by Stephanie Studensky, and shows how accurate gait speed actually is for predicting mortality. So if you look at that top arrow, that shows somebody that is age 70, and if they have a gait speed that's pretty brisk, so they can walk about 1.6 meters per second, they have probably 30 years of life left. So that's a very healthy person that we expect should have multiple years of life remaining. In contrast, somebody who's 70 years, who has a gait speed of 0.2 meters per second, so very slow, difficulty mobilizing across the room, probably has maybe 10 years of life left. So just this simple measure can not only help us predict who might need better advanced care planning, who might benefit from geriatrics, and who also might benefit from exercise intervention, some of these therapeutics I talked about, or even just a referral to physical therapy. Gait speed is also a major predictor of who can continue to live in their home, who might we have to start talking about for a nursing home or some other sort of skilled care. And we know that it probably declines faster in people with HIV compared to people without HIV, as we've shown in a couple of different cohort studies. In people with HIV, gait speed is associated with increased falls and fractures, as well as an increased risk of different comorbidities, including diabetes and cardiovascular disease. And so with the support of the Collaborate Award, several colleagues in geriatrics, Liz Kessler in oncology, and some colleagues in physical therapy, we looked at trying to incorporate gait speed within the HIV clinic. This device that's pictured here is courtesy of Thomas, one of the geriatricians who set up this device in the geriatrics clinic, or the seniors clinic. And we've since installed a similar device in the HIV clinic. We now have gait speed that's available as a vital sign that pops up in Epic. It shows up as red if someone has a slow gait speed, and then we can follow this over time. So hopefully starting to think at least a little bit about some of these functional measures. It probably gets measured about 40% of the time in our clinic, so we still have some room for improvement, but I think it's at least made some of our providers kind of think about function. There's certainly a lot of other opportunities to improve aging care in the HIV clinic. One other example is Medicare annual wellness visits. So many of you probably do this in the seniors clinic or in primary care clinics all the time. I think we had 0 billing for annual wellness visits in the HIV clinic, so it's not something that we've typically done. But I think it can help to improve care. It helps to make sure that everyone's getting age-appropriate screenings and interventions. And it also can help to maximize revenue in our clinic. So something that, a missed opportunity. So with one of the SEPS grants, we're going to be testing or trying to roll out more Medicare wellness visits in our clinic, in the HIV clinic, and see how this can help improve care. So I would be remiss to not mention the impact of funding cuts. I talked a lot about improving the health span of HIV, but I think unfortunately we've taken a step back and we're now again concerned about the lifespan of people with HIV. The cuts to HIV prevention and treatment over the last 4 to 5 months have a marked impact on how we think about the HIV epidemic. Some of the modeling estimates that cut support for things like PEPFAR that provide antiretrovirals internationally estimate that 10.8 million new HIV infections and 2.9 million deaths may occur in the next few years. And cuts to Medicaid are probably also going to impact how we can care for our patients and many of these comorbidities that I just mentioned. We also have a lot of psychosocial needs in our clinic. We have psychiatrists that are in, social workers that are in our HIV clinic, and a lot of the additional supports that we rely on are also at risk for being cut. So I don't know that a lot of these topics that I just discussed will hopefully we can continue to focus on healthspan over the next few years and not take a step back. Because we have a lot of learners in the room, I also just wanted to touch a little bit about some lessons that I've learned. I came as a fellow here in 2008 and actually didn't intend to do research at all, but I really fell in love with it. And I also discovered that research doesn't mean one thing. I did not have any interest in going into the lab, and I think I've discovered the multiple different directions that research can take. And so for those of you who are thinking at all about it, Embrace the Journey explores different kinds of research, and it can mean a lot of different directions. I think the multidisciplinary aspect of any research makes it much more fun. HIV sets itself up nicely for multidisciplinary research, and team science is certainly so much more fun than sitting in an office by yourself. And then lastly, I've learned so much and kind of directed my research towards what I hear from my patients in clinic. And so getting that feedback from your patients, having opportunities to present at community advisory boards and getting feedback as to what they think is important has been incredibly helpful for me. And so in summary, older adults often have delayed diagnoses of HIV. The majority of people with HIV in the US are now aged 50 or older and probably experience an acceleration of the aging process, but targeting these hallmarks of aging can hopefully ultimately prevent the onset of chronic disease or delay the onset of chronic disease. People with HIV may benefit most from gerosciences approaches to prolong the health span, and incorporating these approaches into clinical care will be key to prolonging health span and supporting our patients aging with HIV. And with that, I want to acknowledge all of our study participants, study team members, including my research coordinators, statisticians, mentees, collaborators, funders, many of whom I couldn't list here in pictures or show. This is a sample of some of our research team at the HIV and Aging International Workshop presenting some of our research last year, and then several funding resources and networks that I've had the opportunity to work with. And with that, I am happy to answer any questions. Thank you.
Well, while people start warming up for questions, I do have a question for you. So exercise could be a panacea, and you have obviously demonstrated that. I personally have exercised more because of you, so thanks for that. Is there a time in life, in the lifespan, in which exercise, the benefit of exercise is beyond, like you don't really get any additional benefit, or should we consider exercise in anybody at throughout their health, their lifespan?
Yeah, no, I think that's a great question. Certainly, I think anyone can benefit from movement. The extent of their exercise may be limited by functional impairments later in life, but I mean, we have patients in the ICU that still get physical therapy because we know that moving can be helpful for maintaining muscle mass and maintaining function. In some of those older patients that do have a lot of impairment and may not be able to do that higher intensity of exercise that we know has the most benefit, I think that's where we may need to rely on some of those gerotherapeutics. So are there ways that we can complement exercise and complement more minimal movement to really maximize the benefit?
Kristine, fantastic talk. Thank you. One, I've learned that I have to practice gait speed, apparently. And two, as toward the beginning of your talk, you talked a lot about the early interventions that we need, especially around cardiovascular disease. What are the differences and approaches to get people earlier, especially maybe HIV versus not HIV, to be adherent to medications, especially for longer? If somebody told me that I needed to start taking a statin at 40, I probably wouldn't take it. And so is it a different population with HIV? Is it, and are there strategies that work better?
Yeah, no, I think there's a couple points. First, I think many of my older patients had a much different message when they were diagnosed with HIV. At the time, they were focused on living. They actually didn't think they were going to live, and so many of them kind of lived different lives early on and didn't practice much preventative medicine. I think our younger patients now actually pushing the message of these other conditions are going to be the biggest thing that you're struggling with as you get older. HIV, once you're on your treatment and have that well controlled, that you really don't have, like HIV is kind of in the back burner. It's managing your cardiovascular disease risk that may be worsened by your HIV or these other factors. It is hard. I have a hard time, many of my 40-year-olds that I say, hey, I think you would benefit from a statin, they're like, no, I'm not taking that. So I think kind of emphasizing, and we talk a lot about the REPRIEVE trial, we watch their lipids, trying to convince them that they want to take it. I don't force them to, because I mean, it's likely they're not going to take it. There's a lot of other benefits that have come out of the REPRIEVE trial that we're starting to see from statins, and then a lot of studies that have shown a lack of harm on things that we thought might be harmed, like cognitive function. So I think the more data that comes out of that, that we can help them have an informed decision about the risk benefits over time. Some studies have shown decreases in cancers with statins, and so I think if we can see benefit on multiple disease outcomes and kind of this gerotherapeutic, where we're impacting multiple processes, that may be more convincing to someone to take these preventative medicines. But we also struggle with polypharmacy in many of our older adults, and we don't want to overwhelm them to the point where they don't want to take any medication. So it's definitely a balance.
Thank you so much for this talk. It's so great to have so much advocacy for our patients. Did you guys stratify by ART regimen in any of these? Was it the same regardless of which ART they were taking?
Mm-hmm.
And did it matter if they were virally suppressed or not?
Most of our exercise studies, we've really just focused on patients who are virally suppressed as how can we further optimize care. I think we've talked about, should we, and Jose and I talked about that a lot before, should we try to get, can we improve antiretroviral adherence if people are exercising? Like, would that help overall? Some of the older studies, we do see that people who had older drug therapies, so people who had AZT, did respond a little bit differently to some of the interventions. For prior AZT, most of our patients are now off of AZT. We've seen that some of the older, like efavirenz, was associated with more frailty, people who had been on efavirenz, but most people I think have been transitioned off of that. In terms of newer therapies, we haven't seen a huge change in a lot of those, but it's something in our larger trial we're beginning to investigate right now. And REPRIEVE has looked at kind of some of the impact of statins based on what antiretroviral therapy people are on, and again, saw greater cardiovascular disease risk in people who are still on abacavir. Not surprising. So a little bit with some antiretrovirals.
Great talk. I want to switch to bone health. Your case reflected osteoporosis. So can you tell us more? Is osteoporosis specific to HIV, or is this a model of aging in other at-risk populations?
I think a little bit of both. One of the older drugs that we used for HIV, tenofovir disoproxil fumarate, or TDF, had pretty significant bone toxicity. And there also seems to be something that happens in the immune system at the time that people start antiretroviral therapy. So we see this this quick drop in bone density right after ART start. No matter what people start, they drop about 10%, I think. So there's a fairly good drop in bone density right at the time, regardless of which therapy. Some of that will revert back to normal. And some studies have actually looked at giving zoledronic acid at the time people start antiretroviral therapy and completely block that initial decline. So it seems to be some immune system changes there too. A lot of our patients have additional risk factors for low bone density. We have higher rates of smoking in people with HIV, higher rate of other substance use, hepatitis C, low physical activity, poor diet. So I think some of it is also exacerbated by some of those behavioral factors that may impact bone density. But it certainly, I think, also could reflect an acceleration in aging. As people transition off of that TDF, we haven't updated bone screening guidelines, so we may see a little bit different bone density with newer antiretroviral therapies, but we don't have that data yet.
Question in the front.
Hi, yeah, thank you for the talk. Similarly to a lot of the other questions I've been asked, are there what's the literature like for other age-appropriate screenings like breast cancer or colorectal cancer with the given accelerated aging in HIV populations?
Interestingly, it differs by disease. So some conditions we think are accelerated with HIV, and some actually probably we catch earlier in people with HIV because we're screening them frequently. So breast cancer, same recommendation. There doesn't appear to be an increased risk. Prostate cancer, we tend to catch earlier prostate cancers, but the risk of advanced prostate cancer doesn't, or the risk of prostate cancer in general doesn't seem to be different, and same with colorectal. It's a lot of the cancers that are more inflammation driven or viral driven. So hepatitis C related liver cancers, anal rectal cancer, cervical cancer that have HPV virus, those really seem to be accelerated. And then a lot of the comorbidities in general, like lung disease, we see more commonly, lung cancer, we see more commonly, diabetes, cardiovascular disease. So it's very disease specific, which is kind of interesting as to what's the mechanism and why do we see that. A lot of it seems to be things that are driven by inflammation or specifically from toxicity from antiretrovirals.
Any other questions? Well, thank you again. This was an
Thank you.
excellent talk. Congratulations. Thank you.